So today I'm going to talk about a few different areas about advances in new research in the field of general heart disease, especially over the last year or two. We're going to cover four main areas. First, reviewing some new findings in the development of general heart disease, then go over new things that are happening in the diagnosis of general heart disease world. The management of general heart disease, and then we'll end up with long-term outcomes, which I think is the most important part and the most relevant to this. So, first, we'll talk about a few things. One of the things I can tell you every time families come into SU, and I wish I had answers for you, they always want to know, how did this happen? Is there something I did? Is there something that happened? The vast majority of times we don't know, and we're not sure. One of my big goals and dreams of a researcher is we could have no children born with heart disease. I know that there are certain diseases, let's take spina bifida, for example. How many women, when we were pregnant, took extra folate? Right? That was all because of spina bifida and the nerve defects that can happen to the neural tube, because researchers found that if you take extra folate, you can decrease those risks. For general heart disease, unfortunately, we don't have that magic bullet yet. We haven't found anything that can help decrease that. We have a lot of things that are candidates and lots of things that have been studied. And we find little things here and there which increase the risk just a little bit, but nothing that's going to be a big silver bullet to knock out the disease. With that being said, we don't stop trying. Allison said I work with the CDC and do a lot of research in development of heart defects, and some of this stuff I'm going to talk to you about is research that's come out of the CDC over the last 2 years, trying to identify certain things. All of these things are just very small differences in risk, and none of them are something where I could say that if you didn't do this, you would absolutely not have to go. We don't have anything that's common. But I think it's still important to mention. So the first one is association between maternal fever and influenza and general heart defects. I helped lead a study with other people at CDC. And this is based on old data. And in the 1980s, there was a huge study based out of the DC area called the Baltimore-Washington Infant Study. And a lot of what we know about risk factors for general heart disease comes from the data collected in that study. They interviewed, almost over 4,000 families of children with general heart defects, and they interviewed 3,500 families of children born at the same time or in the same area who didn't have general heart defects. So a lot of what we know comes from those types of studies. Okay? And the way that these studies work, they interview moms and they ask them, did you have a fever? Did you have the flu? Did you take this medicine? Did you live in a house that had these pets? Did you live in this area of the country? All different types of questions, and then compare those to the kids who didn't have heart defects. And they try to see if any patterns emerge. Lots of studies happen like this in epidemiology. And so one that we looked at recently was asking mothers about fever and flu and whether they had that or not. And what did we find? Well, we found that if moms had fever or the flu during the first trimester, it might be associated with certain types of congenital heart disease phenotype, CHD, congenital heart disease. Most notably, right-sided obstructive lesions. Those are like your tricuspid atresia, your pulmonary atresia, those types. And then also kids who had atrioventricular septal defects associated with Down syndrome, their mothers were more likely to have reported fever. Small increases in risk, but they were real and they were repeated. But they also noted that if those mothers also reported they took medicine to treat the fever, antipyretics or Tylenol, for example, that their risk actually came down. So this kind of suggests that there might be some certain, fevers or influenza which can alter development of the heart in the fetus in the early stages. Rubella is one that was studied a long time ago, which is known to be a viral pathogen, which can cause heart defects. And this leads us to think there might be others that we haven't really fully investigated. So the take-home point here, pregnancy, the flu shot is already recommended for mothers, but that just strikes on the point. Get the flu shot for mothers who are trying to get pregnant. If they do develop a fever, take Tylenol, maybe it can reduce it. Another one that came out recently was maternal smoking in congenital heart defects. Again, looking at data from the Baltimore-Washington Infant Study. This is by some other people at CDC as well. We already know smoking's bad, but can it cause congenital heart defects? Well, maybe. There were very slight increases for right-sided obstructive defects. Again, that's the pulmonary atresia, tricuspid atresia, atrial septal defects, your ASDs, truncal arteriosus, and transmission to great arteries. Again, really small increases, but The data did suggest that. So the take-home point, if you don't know already, smoking's bad. And this just makes it seem worse. Should say, I forgot to say earlier, by the way, any point, if anyone has questions or anything, please stop me. It's perfectly fine. If I use abbreviations or anything you don't understand, please interrupt me. No problem. Okay, the next study that came out of the CDC this past year was association between pre-pregnancy body mass index and congenital heart defects, a large group at CDC and also throughout the country. So first, you may recognize this picture from the week. What is body mass index? So body mass index is weight divided by height squared, and it's kind of an estimation that we use in the medical world to identify obesity or overweight. Ideal areas, in the ideal section you see here are kind of your BMIs between 18 and 25, which is about 1% of the population these days. Overweight about 25 to 30, and obese is considered over 30. And we use this to track just progression because your ideal body weight changes, especially as children grow older, and the BMI is a little bit better estimation of how much you want them to do. But this is for mothers before pregnancy. What was their nutritional status? This data was from a different data source. This is an ongoing study called the National Birth Defects Prevention Study, which some people here may actually be part of, especially if you're born in Atlanta. So Atlanta is one of the 10 sites around the United States that participates in this. This study identifies a certain subset of mothers who have children with congenital heart defects, and also identifies certain children who don't. And then they fill out these very long questionnaires about exposures again, similar to the Baltimore Washington infant study, but it's more national based and still collecting data. And this one looks at more than just congenital heart defects. They look at spina bifida, they look at cleft palate, they look at just all sorts of different types of birth defects. And it's ongoing and has a lot of great data stuff. What did they find in this study? Well, they found that elevated BMI, so overweight is above 25 or higher, associated with a small increased risk for tetralogy below, hypoplastic left heart, those right-sided obstructive defects, again, those keep coming up a lot. There's seems to be a lot of things that cause this. Atrial septal defects and total anomalous pulmonary venous return. Again, small increases. Can you say that if the mother did not have, was not overweight, that she wouldn't have had these problems? No. But it is something to keep in mind. So the take-home point is a small increased risk, and this is just yet another reason why the obesity epidemic in America is a big concern. It's something we should be concerned about on a national public health grand scale. Okay. Yes.
Has there been any studies environmental issues?
Yes.
Where I was living at the time, we had a chicken industry in town and talked to several other people with kids who had congenital heart defects who lived in towns with some type of chicken industry.
Yep. So there are a lot of studies looking at environmental factors, and the CDC does a bunch of that. And Rollins, who's a good person I work with closely, who's very involved in that in the Department of Environmental Health. The results from those are not as clear cut. They're still studying them, let me say that. All the time they get these, CDC gets these calls to action where people say, gosh, it looks like in this town, there's a big spike in the number of heart defects. And they look at these studies and they haven't been able to identify certain clear-cut ones. Certainly some of the other environmental toxins were known to be bad, you want to avoid, but it's something that's definitely on people's radar, that people are interested in, still being studied. It's just things that are very, very rare in rare exposures, rare toxins are very hard to draw conclusive analyses from. That's a good question. Okay, so next I'm going to move to diagnosis of heart disease. I want to stop for a second here. I want to ask you. So, how many people here have had a child who's had surgery for congenital heart disease? I think that's pretty much most people. Okay, keep your hands up. All right. If your child had surgery under the year of 1, keep your hand up. Oh, wow. Okay, good. If your child was diagnosed after they were born, keep your hand up. So if you're diagnosed prenatally, okay. If your child was diagnosed after they left the hospital from the newborn nursery? Okay, 2. Curious, what did you talk about?
He was single ventricle transmission of the great arteries, ventricular inversion, pulmonary atresia, and like umbilical.
And went home from the hospital. when
Yeah, he was
born.
9 days old when he was diagnosed,
Okay.
and he was life flighted and had emergency surgery the next day.
Okay. Good. And went home. Okay. All right. Scary. I bet, right?
Scary.
I bet one of the first questions you asked is, how was this missed? Right? Like, how could he go home from the hospital or something like this? That is a question that's being asked on the national scale. And that is a question that hopefully we are trying to answer. So, I'm going to use hypoplastic left heart syndrome as an example, but your 2 diagnoses follow this example to a T. So there are certain types of lesions, many of you know in here, where the PDA, the ductus, that little artery between the lungs and the rest of the body needs to stay open after the child is born, or else they can have problems. 9 days old, when the ductus closes, your child will have problems.
Yeah. I took him the regular pictures, and I thought he was a little bit pale, and I was like, you might call me crazy and send me home, but I think my kid's a little pale, and his SATs were 50.
Yeah, exactly.
Wow.
So when that ductus starts closing, we've got problems, and we've got them fast. And so we want to find those problems before they happen. Hypoplastic left heart is a great example, where the ductus here gets, let me start back. Blood comes to the right atrium, goes to the right ventricle, goes to the lungs, but if this is open, it allows it to go to the rest of the body. If that closes, we have problems. So we want to pick up problems in these kids before that closes. On the other hand, when this is open, those kids can look great. They can go home from the hospital, look totally fine, but it's a normal process for this to close in newborns. That is part of the normal development in the first week or so of life. So the question is, can we diagnose these kids beforehand? Obviously, yes, if we did an echocardiogram of every single child when they were born, we could pick it up. That's not realistic. Those are expensive, they're time consuming, they're not available everywhere. It's not going to happen. We do prenatal ultrasounds on almost every mom, but it's hard to see the heart in those. We can't pick up everything. Things get weird. Most people here were not diagnosed. Kids were not diagnosed prematurely. So, this question on pulse oximetry. All of you should be familiar with pulse oximetry. That's when they put the little probe on the hand of their foot, check the oxygen saturation, and see what it does. So in August 2009, Bill Bailey's a physician with Sid that many of you may recognize. He helped lead a group that looked at what's the role of pulse oximetry in examining newborns for congenital heart disease. Every child before they leave the nursery gets a number of screening tests. And they get that little blood spot done, and get tests for, different problems with their hemoglobin or sickle cell or PKU or things like that. These days they also get a hearing test to make sure their hearing is fine, get all these done. They don't get anything to check for their heart. They get a regular exam, they don't get a check for their heart. So the question is, if we can do a pulse ox on them, can we find the kids who are at risk for that ductus closing? Because even if your saturation is like 85%, which is not normal, you can look like a rose. You can look perfect. So we want to find those kids before they leave the hospital. Well, this group said routine pulse oximetry performed up to 24 hours in hospitals that have on-site pediatric cardiovascular services incurs very low cost and risk of harm. Sounds like a reasonable thing to do. But they said future studies on larger populations across a broad range of newborn delivery systems are needed to determine whether this practice should become standard of care in the routine assessment of neonate. So they stopped short. There's a big group brought together by the American Pediatrics and American Heart Association to study the issue, saying, should we do this? And their answer was, maybe. It didn't really help a whole lot in 2009. They said we need more data. So later that year, actually around that same time, there was a large study that was published. This came out of Sweden. Scandinavian countries are great at doing large population studies. They don't have privacy concerns that our country has, so they can get data on everyone in the whole population, and it allows for great research studies. So they looked at pulse oximetry. They did studies in their own country saying, if we did pulse oximetry, can we find these children before they go home? And what they found is that if they do pulse oximetry screening before discharge, they can improve their total detection rate of duct-dependent circulation. So those lesions where we need the duct to stay open to about 92%, by 92% in cases. It's said such screening costs seem cost neutral in the short term, meaning it's not going to cost us any more compared to the savings that we're going to make, and it might actually save money in the long term because of prevention of neurologic problems and reduced need for preoperative neonatal intensive care. That seemed to be that this was a good idea. So, enter the Secretary Advisory Committee on the Heritable Diseases of Newborns and Children. This is a group, it's a committee that is part of Department of Health and Human Services, HHS, that operates under the Secretary of Health and Human Services, Kathleen Sebelius, and they are responsible for deciding which tests we should recommend that all the states have in their screening profiles. So the PKU screen, the sickle cell, all that, that comes from this committee saying, we think you should do this, and then it's up to the states to decide. So they posed the question, should pulse oximetry be part of the recommended screening panel in the United States? And there are a lot of issues to think about when you have a screening test. It's not a slam dunk, it's not a clear-cut thing. First, you have to think about the availability. This is for all screening tests. Availability of testing. Can we test everyone? Pulse ox is pretty standard these days. All hospitals pretty much have it. You just need to make sure they have a good neonatal probe. You can't use the adult probes. So that seems to pass that test. Availability of cardiologists. In Atlanta, we've got quite a few. But if you go to some more remote areas, they're not always there. So if you're going to say, well, this pulse ox is low, this child needs to see a cardiologist, we're going home, that could delay discharge, trying to be able to see someone, it makes things a little tougher. The logistics get complicated. It's not like when you do the hearing screen, you don't need to fix that right away. The kid's still going to be fine. You need to fix the heart pretty much sooner, or else they're going to have problems when they go home. What about false positives? Are we going to identify kids that by the pulse ox test seem like they might have heart disease, but they don't? Are we going to add stress to these families that really didn't need any added stress because their child was normal, but the test just said that they weren't? What about false negatives? We're not going to catch everyone. We're going to tell some families, hey, we did this pulse ox test, things look good, you're fine, but really it might not be. Their stats may still be okay, even though when that doctor closes, it's not going to be okay. Cost. Everything in medicine costs us an issue. You should all be well aware of that now. Pulse ox test actually really isn't that expensive. I think it's like $2. It's really not a big cost in terms of a money type of thing. But time resource costs, so other resources, the nurse has to do it. We've all seen, your children at the bedside. Sometimes it's hard to pick up if you're breathing. It's hard to tell. You need to repeat the test. Those become issues. So where does this stand right now? Well, I can tell you that Bill Manley helped lead a group, and I attended their meeting back in January that had to advise the secretary on this, and it looks like things are moving in the direction that this is going to be recommended. I can't say definitely, because Kathleen Sebelius has to review everything and make the final determination, but it's headed that way. If we were in New Jersey right now, I would tell you that this will be recommended. New Jersey actually just passed a bill that is going to require all hospitals to do pulse oximetry screening in the newborns. States have the option to do it on their own. Georgia, just finished the legislative session, did not have that bill in their session. But if the secretary comes and recommends this, then the states will need to either say yes or they need to explain why they don't want it. So that might be coming. Just for future kids, I know it's not going to help the kids anyone here now, but I think it gives people peace of mind to know that other families coming may not have to go through. Yes?
At Wellstar Health Hospital, we do the pulse ox screening on our own.
So some are either, right, so some hospitals can do it on their own, and there are a few that do it. But it's not, Northside doesn't do it, Emory Midtown doesn't do it. Yes.
Can you request it? Because I've had friends that have had babies, and then once I had mine, and they were like, "What should we do? What should we ask for?" And I said, "I'd ask for a pulse oximetry
You can request
test."
anything.
Or okay, I didn't know if that. I
can't say about what they'll do. It's again, it's not expensive,
Right.
And it's something where the recommendations that they're saying for the screening to try to minimize the time disruption is to do it at the same time as the hearing.
And what about
Because you can just put it on there, let it do its thing while you're doing the hearing test, so it shouldn't be harder.
what if they would have done? Because I remember when I was in the hospital, my son was up in Kansas City, and there was a nurse that was pregnant and asked questions about if I knew and if I would have known would have been different or worse or whatever. But she had said something about doing four for cuff.
For
Yeah,
blood
4-point
pressure.
blood pressure, and would that have made a difference?
That can find certain things.
Okay.
So for the blood pressure, that's usually looked at as a roulette or cohort, because the blood pressure is gonna be higher in the arm than in the leg. That being said, if the duct is open still when the child is born, it could be fine. You might not have a blood pressure differential. You might not see the cohort until after the duct is closest. That's number one. And number two, try to get a blood pressure on a newborn.
Oh, yeah, I behave.
That's going to be fraught with difficulties, I think, especially one of the large. Yes.
This pulse ox test, this is when you put the thing on the finger when you put a piece of tape?
Yep.
Yeah.
And so how long have you been debating that? I mean, honestly, for
Right.
$2, are you kidding me?
Right. Well, so the issue is availability. So pulse ox in kids is not. It's really in the last 10 years has become widely available. So it's more of an availability thing and a cost and time thing, and does it work thing. So that's the other thing. They don't want to do a test that doesn't work. It's not 100%. This isn't going to catch everyone. And if a child has, let's say a child has a pulse ox that's 85. Let's 85 is American Heart Association. Let's say 94. Okay, so I think the cutoff thing to use is 95. Let's say 94. Chances are that child does not have congenital heart disease. Okay, that child just still has some fluid in the lungs, or that child has a lung problem, maybe it just has an infection in the lungs, or has something else going on. Chances are still that child does not have congenital heart disease. But if a child has congenital heart disease, hopefully they'll still be in that group too. So it adds a lot of other resources because the cost from the test are only $2, but it adds extra echoes, it adds extra time. But that's why now we think that we've gotten to the point where we can say the data supports and the technology is available that we can do this in a reasonable fashion.
Yeah, she's too chicken to say it, but my wife Melissa, she formed a group about doing this in Georgia.
Uh-huh.
And she's actually working with a friend of mine who's a state legislator
Great.
about doing it in the next legislative section.
Yeah. I'd love to get involved. Yes.
My daughter had a whopping murmur in the
Mhm.
hospital, pediatrician, not concerned. Is there a way to determine what's of concern and what's not, as far as the murmurs go? I know lots of babies have.
Yeah, that's hard to say, and I know here a lot of times we hear murmurs, we get the cardiologist involved and check them. It's hard to say in general because as many of you know, a lot of murmurs can be normal, but the ones that are normal can sound very different, and we need to get used to them. So it's hard for me to say without. Any other questions about this? All right, so now we're going to move on to management of congenital heart disease, and I'm going to talk about a couple of them in general, a couple of specific ones before I get to the general stuff. So, how many parents here have children who have hypoplastic left heart syndrome? Okay, so 3 here. And did your children have a BT shunt or a Sano?
BT.
BT.
My son has tricuspid atresia, but he had a BT.
Okay, you have a BT. All right. So a lot of kids have BT shunts. So this is the BT shunt. And it was pioneered in hypoplastic left heart, but it's used for some other diseases as well. So I showed you hypoplastic left heart again, where the left ventricle is not big enough, the aorta is really small. So what they do here is they augment the outflow tract, and they make the aorta much bigger. Okay? And they make the right ventricle go out the aorta instead of going to the lungs. And to get blood to go to the lungs, they introduce this little conduit, the shunt, going from one of the arteries, the nominal artery, down to the lungs. Okay? And they've been doing that for years. And that's been around since the 70s. That's been around since the BT shunt was invented in the 40s. And it was used in hypoplastic left heart really since the 70s with the rest of this normal operation. It was working well. Kids were doing fine. But then they started noticing problems with the shunts. The shunts were cutting off. There were big concerns about the coronaries. And people wondered, is there another way to do it? So entered Sano shunts. This is another one. We work with the Sano shunt. So instead of doing the blood flow to the pulmonary arteries coming off the pulmonary artery to down to the pulmonary artery, they cut a hole in the ventricle and just introduce a bigger shunt going from the ventricle to the pulmonary arteries. Pioneered by someone in Japan, and to be honest, part of the reason he did it is because he was bad at the BT shunt. And he said, I got to do another way because my kids aren't doing well. So he pioneered this way and started getting better results than the people who were good at the BT shunt. Or at least that's what it looked like. So the big question, which one's better? So this is a good example of around the country, all the surgeons had this debate, which one should we do? Some surgeons had a preference of one, some had a preference of another. No one could agree, but it seems like we should figure this out. So a few years ago, this huge study that was started, it's the SVR trial. I don't know if your children were in the SVR trial, where kids with hypoglossal left heart syndrome would come in and be randomized to get either the VT shunt or the stent. Okay? And we would compare the children long term and see how they do. So early results just came out a year ago. Comparison of shunt types with the normal procedure for single ventricle lesions, hypoglossal left heart, and other single ventricle types. And so the early results are 1 year survival, so kids to live between, to make it to their first birthday. Sano did better. About 74% of kids lived to their first birthday in the Sano, and about 64% with VT shunt. But after 1 year, no real difference. The kids kind of survive at the same rate after that. So Sano loses its luster after a year. Fewer complications, unintended interventions, VT shunt. So the Sano had more problems with it. It had more need to go back in, to readjust it, to do the cath, and that causes extra morbidity. What about ventricular size and function? How was the heart doing when they looked at it by echo? No difference. They were doing pretty much well by both of them. At about a year of age, they had these. What about long term? What about when these kids are reaching 3, 4, 5 years of age and longer? Way too early to tell. We don't have the data. So what we have now, they've stopped enrolling kids, now they're just following them long term. If your kid actually came to CHOA today with hypoglossal left heart syndrome, probably the Sano. Our surgeons have moved more towards the Sano camp, and they like that, mainly I think for the short-term outcomes. But if this study says that the VT shunt is better in the long term, they may move back towards the VT shunt plan. Yes?
They're gonna close my son's VT shunt this summer, and
Yeah.
they said it should have closed already.
Yep.
I thought they were only short-term. Did
Right,
children look at
so
long-
these are the groups, so the Sano and the VT shunt both are taken down when they get their blend, so for the hypoglossal left heart kids. So they're taken down at 6 months, but they still want to see, what happens after 6 months, they think still has effects long term. So we're still following these kids long term. But yes, that's perfectly normal, that we don't expect the VT shunt to last forever. And we do use the VT shunt in certain diagnoses for certain kids other than hypoglossal left heart, just to kind of bridge them and see how they do, and then we'll evaluate them long term and say, do they need another surgery? Are they doing fine? Do they need a shunt anymore? Every child's different, and we individualize it for each kid, so it's hard to make judgments like this in these large studies, but for kids who have similar diagnoses, we do want to have a similar game plan approach each child. Okay. So the take-home point, Sano seems better in the short term, VT shunt may be better in the long term. We really need more follow-up before saying for sure. Again, this isn't going to affect anyone here. This next one might affect some people in here. How many people in here have a child who had an RV to PA conduit? And so diagnoses that this could fall under tetralogy below, pulmonary atresia, truncoscariosis, aortic valve disease, if you had a Ross procedure, transposition of the great arteries. All right, okay, so many people in here. So if your child has conduit going from the right ventricle to the lungs to try to help get flow there, or just something going across the pulmonary artery, you may have needed to have a pulmonary valve replacement. Did you ever hear saying your child needed the conduit replaced recently, or anything else done?
2 years ago, she had a conduit replaced.
Okay, so 2 years ago, your child had a conduit replaced in a surgery, right? Okay. So the conduits have a lifespan, about 10 years or so, big spectrum. Some last a year or two, some last 15 years. Big spectrum, but on average around 10 years or so. But they don't last forever, especially for kids. They outgrow them. They get bigger than their conduit. They need a bigger conduit. So you can have dysfunction, abnormal right ventricular function, pressure load because it's obstructed and makes the ventricle work harder, volume load with blood coming back. There's not a valve there, so the ventricle gets much bigger. And that's the obstruction is pulmonary stenosis, the regurgitation, pulmonary insufficiency. It can lead to exercise intolerance. It can lead to arrhythmias. It can lead to increased risk of sudden death. Lots of things we'd like to avoid. Okay. So your child had a conduit replaced, and they probably told you that it may need to be replaced again in your lifetime.
They put an adult test one in this time, so.
Right.
That was
it may need to replace again. They don't last forever. Okay? Surgical replacement of the RVOT, that's right ventricular outflow tract conduit, has its concerns. Your child has to go back on bypass again. We do this routinely, but I know no parent likes their child to go on bypass. I don't like it. They tried some other things. They tried just putting stents up in there in the cath lab. It addresses pressure load, but they have lots of insufficiency coming back. So 2 years back, somebody got the bright idea, well, what if we put a valve on that stent? So they decided to take a bovine cow valve from the jugular vein of a cow and put that on a stent that they can put in the cath lab. You don't need to go through surgery. You can go through the cath lab and put it in there. You just need to have a wide enough opening. It's called a Melody valve. And it addresses both pressure and volume of load from the RVOT conduit. There's a little history of it. So September 2000, kind of started doing the first one that was in France, the first in an adult. They revised it, they noticed some things weren't perfect with it over the next few years, and then it was finally approved in the United States in January 2010 to be used. And in March, there were some big studies coming out saying this might seem to be a good thing.
Is that typical, that length of time?
Yes.
All that time?
Oh, absolutely. Yeah, it takes a while for things to happen. So at Chilla and at Emory, we've been doing this now since August of last year.
Next
It's going well. So we've done 7 now at Chilla and 5 at Emory. And we have some data on the first 10 patients, average age of 15 years, but range from 11 years of age to 16 years of age. So a few kids with tracheal flow, a few with pulmonary stenosis, pulmonary atresia, one with aortic stenosis who had a Ross procedure, one transmission of great arteries. And truncus we haven't done because it's rarer, but it's certainly fitting. So if your child has a condom. And they've had pretty good outcomes ranging from up to 20, they've done different sizes. So the take-home point though here though is Melody seems to be safe and effective. It's been tested over the last 10 years. Further mid to long-term studies, we don't have those yet. We haven't been doing as many now. Additional follow-up data is needed, but if your child would need any sort of condom revision again 5-10 years from now, as long as they need, this might be an option. So if you were told your child needs another surgery for the conduit, I'm telling you, it might not. So you might be able to do a cath procedure to address the conduit. Yes, I think you had a question. Go ahead. Back over.
Stand up so you can
Sure.
Is the Melody valve being used at all for pulmonary stenosis and insufficiency with regurgitation?
It's used for, you need a place for it to sit.
Right.
So I think it can, but they're not using it yet. They're using the conduits because they're a little bit stiffer, and so they know that they'll stay there. But I think they're starting to do some studies to look at it more. And you need to be bigger. And so if kids have bad pulmonary stenosis and insufficiency and they're very young, you need to have the surgery. But if they're older, like adolescent age and older, it might be an option.
Yeah, well, my son was diagnosed after he was born. He was the
Mhm.
baby that turned blue in the nursery at 2 days of life, but still was discharged home because we were in rural North Carolina and still follow up in Asheville,
Yeah.
like 2 hours from where we lived. And when we got there, he was like, critically bad. He wanted to shake his leg. But we came to Edison instead. I turned to treatment with him.
Great.
But now he's 14.
Mhm.
And this year he actually has started to get some right in. So when my husband and I are thinking, what is his next step? We know it has to come in place at some point because he moves a lot and he's got exercise intolerance and he's got some other junk going on. So that was like my, oh my gosh, this is really cool.
So-
thing.
We can do it, and actually I should have mentioned here, there was one kid here.
Yeah,
Adult
that's
kids.
what I was looking at.
So it needs to be evaluated. Not every child is a perfect candidate, but it's on the table.
That's good to know.
You had a question?
Yeah, I noticed most of the tests for older children are age groups. Are they trying to younger children at this point?
Like it's a size issue,
Okay.
and so it needs to be big enough to fit in there. And once it's there, you don't want to really have to go in and do it again. And so you want to be able to put one that can last them through adulthood. And so if you do it in the younger child, who's much younger than younger than 10 or so, they still have a lot of growing left to do, and so whatever valve you put in there might not be good enough for them long term. So we're not doing that right now.
Okay, so she might still need to do the surgery at first,
Mhm.
and then this would become a later option?
Correct.
Okay.
But I don't want to say anything's absolute, because if you learn one thing from my talk, lots of things are changing in a good way, and anything I say now could be outdated tomorrow. So, you might see me again next year with a totally different talk. Yes?
I think you may have answered it. My daughter's now 5, and I was wondering how old would this kind of procedure be appropriate?
Right.
And it sounds like we're in a similar situation. She's had the surgery at birth.
Right.
And has not had, she's had 3 or 4 angioplasties, but has not had the replacement surgery since.
Right.
But I kind of heard about this.
Yeah, the youngest that we've done is 11. Can't say that's the youngest we'll ever do, but it's the youngest we've done so far.
You can read about the 11-year-old in this week's Kids at Heart newsletter that just went out. There's also a story on the news about it. It gives you a lot more detail. And the mother is open to emails for questions, any of our Kids at Heart families that have questions about it as well. Philip Ryder is his name.
Great. All right, so now I think the best part, or the most important for the group here is the long-term outcomes. So, real quick, how many people in here have tried that transposition of the great arteries? Okay, so a few here. Okay, kids have an arterial switch procedure?
Yeah.
You get a Fontan. Okay, so we're different. Arterial switch? Fontan. Okay, so one arterial switch. All right. Arterial switch too. All right, so 2 arterial switches. So this is an example of how I just alluded to. Stay tuned. Things are always changing. We're not sure what we're doing. So I'm going to use transposition of great arteries as an example here. This is a study that came out last year about coronary arteries and transposition of great arteries. So for those who don't know, transposition of great arteries, and we've got the normal heart here, which you're familiar with, is that the aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle. So they're reversed, okay, they're transposed. The procedure to fix that is that they basically will just flip them, but with that they need to move the coronary arteries. So the surgeons are moving the coronary arteries. Okay. If your child had a Fontan, this isn't, if your child went straight through that process, that's not going to be as big an issue because they probably didn't touch the coronary artery. The child has their own set of things to worry about. So that's what they've been doing for the past 25 years or so. What they used to do before that is called an atrial switch procedure, where they go in there and then baffle in the atrium and redirect flow. It was a mess, but it worked. It got the plumbing right. Things were going the right way. And they did those starting in the early 60s to the early 80s. But then, you know that time frame, that's about 20 years or so. They started seeing a lot of problems when kids were getting older. They were having arrhythmia problems, they were having heart rate problems, they needed pacemakers, they needed repeat surgeries, and people said, we need to rethink what we're doing. Okay? We need to come up with another way. And so that's why the arterial switch procedure was born, because they thought, long term, these people will do better than the atrial switch procedures. So that's why that is now pretty much the standard of care is the arterial switch instead of the atrial switch. Well, people are saying now, looking at these kids as they're growing older and becoming closer to adults, and we're starting to see that we might have problems that we may not have anticipated. So there could be about 7% of kids that coronary abnormalities, patients who had more complex coronaries to begin with, will have more problems long term, and the patients might not even have symptoms. I show the runner here, and I should say we had a kid in our group, 17 years old, had a calf when he was like 15, was running cross country, he collapsed. He was transverse great arteries. It's a sad story, and something we wish we could have picked up, but he was feeling great, and he was a great cross country racer. He was in excellent shape, and he had a problem when they did an evaluation of his coronaries. They noticed the surgical site, the coronary was going in, just came off a little bit funny, and they think that's what happened. So, take-home point for the kids by their arterial switch is there may be coronary abnormalities that aren't causing symptoms. Further testing evaluation might be indicated as they get older. So as they're getting closer to adulthood, especially doing exercises or sports, talk to a cardiologist about, does my child need to have coronaries evaluated? We as a group are starting to think there aren't any real guidelines about what you should do. We're asking, should we be doing more imaging, like coronary CT angios to look at these coronaries? But for everyone else, the take-home message is stay in touch with the cardiologist. Stay in touch with, keep coming to these conferences because things are changing. We're learning new things all the time. We don't know everything because we don't know what things are going to be like 20, 30, 40 years down the road because the field just isn't that old. Everyone knows it's that old.
Okay, so if he's already following up once a year like cardiologist wants him to, and doing that normal workup, what further are you talking about here?
Yeah, how old's your child?
7.
Okay, so this is something we start talking about more towards right before they get to adulthood. So, we haven't seen problems in kids really younger than 15, but it's more kind of like in the 15 to 25 year age range where we're starting to, the coronaries become an issue. So keep following, and by then we'll have an answer. Yeah.
Is this a situation where more moderate exercise, limiting my child's activity, would prohibit or prevent a failure? Or
I can't say. Right. Yeah, I can't say. Exercise is good, and exercise helps the heart. But there are certain things where you need to talk to the cardiologist individually, and if they need to do an exercise test to see how your child's heart responds to exercise, whether that's indicated or not, they'll order that. I'm not going to talk about that in a second in my next section. Yes?
would a child with a pacemaker get something like this, or is it the other type of heart defect?
No, it's a heart defect where they actually have to go in and surgically move the coronary arteries.
Oh, okay, so,
No, it's a little bit different from pacemaker. Okay. So, I've given you a lot of bad news about that. Let me give you some good news. Okay, let's end on a good note. So, this study came out from the CDC last year. Mortality resulting from congenital heart disease among children and adults in the United States from 1999 to 2006. And looking at all the data, they looked at birth certificate and death certificate data and mapped things up and figured out how are people with congenital heart disease doing. Short answer is they're doing great, especially compared to 20, 30 years ago. Just from 1999 to 2006, so just in that 7-year time span, mortality from congenital heart disease decreased 24%. That's huge. That's amazing. The biggest change is in the younger age group, but what we're now seeing is more and more adults. If you aren't aware, you should know that in 2005, when we reached the magic number, since 2005, there have been more adults living with congenital heart disease than children. That's awesome. That's something that many cardiologists did not think they would see in their lifetime. Right? So more adults living with congenital heart disease than children. That's great. Among those who survived past 1 year of age, the deaths, 76% of deaths were occurring during adulthood. That's great news. That the kids, once we get kids to 1, we're basically saying we feel like they're going to reach. Yes?
again, is this data pertaining to children with pacemakers, or are you just talking about?
This is all congenital heart disease. So if it's listed as congenital heart disease, so if you're talking a pacemaker for congenital heart problem, then they would have a pacemaker group. They've always had good mortality results. So this is really more in the structural defects. The next section will be applicable to everyone, including pacemakers. So the take-home point: people with congenital heart disease are living longer and longer and prospering. And that is wonderful news. It makes me very happy to know. So with that, though, comes new horizons, new challenges. So as more and more kids are living with congenital heart disease, more and more issues are coming up. Many people went into pediatric cardiology because they don't like working with adults. But now they're living. Many people went into adult cardiology because they don't like dealing with all the structural defects. They like dealing with people who have normal hearts that are just kind of wearing out. So you've got all these kids, all these people who have abnormally formed hearts who are reaching adulthood. Who's going to care for them? That's a challenge. That's a big, big issue. Right? And so transitioning those kids to care becomes, very important. Let me just get a sense here. Adrian, how many people in here have kids who are 10 years of age or older? Okay, a good number. Y'all definitely need to listen. Everyone else, I'm glad you're here. Keep this on your radar. This is important long term. So, just this month, actually, this was published, came recommendations for managing transition to adulthood for adolescents with congenital heart disease, transition process, and medical and psychosocial issues. I'm going to talk just about what the recommendations were from this article, and then I'm going to talk about what cities there were. So, for parents, first recommendation for parents, what should you be telling your parents? First, cardiologists should initiate discussions on transitioning planning and partner with the parents in the process. We want you all to be part of this. We should solicit information about you, about your child's quality of life. That's what QOL means. We should encourage discussion of parental understanding of the child's disease and concerns in relation to future goals. And we should be non-judgmental and empathetic. That makes sense. Hopefully we are always like that. But those are no-brainers. The biggest ones come to the adolescents. And as kids get older, they need to start taking responsibility for their own care. It used to be fine if parents would just manage everything for the child because the parent was always going to be there. Kids are living, they're reaching adulthood, they're leading normal lives. We're really working to try to get kids to, take control of their own, health care, especially as they get older. When I did rotations of adult congenital heart disease, I can tell you how many times I'd see a 25, 30, 40-year-old who was there with their parents. Which I'm glad the parents are still involved in, but at some point we need to cut it forward. I know you don't hear that. You've got this child who's needed you so much, you've done some great things, but it's important as your child grows older to help encourage them to take responsibility for their own care.
8 years old.
Yes. It's okay. So for adolescents, the timely transition should be guided by emotional maturity and developmental level as opposed to chronological age, transition planning. That sounds nice and good, but it gets really wishy-washy. So we, as a group, have kind of said, and other reports have said, at 12, start the discussion. Okay? With the goal that by the time the child's 18, they can transition to the adult congenital heart disease clinic. Y'all are lucky. You were able to travel here this morning for a 9 o'clock conference, which means that you're able to travel to Emory for an adult congenital heart disease clinic if your child would need it, if they're still in the area. Emory has a fantastic adult congenital heart disease clinic. Dr. Michael Connell is one of the Sibley cardiologists. He sees kids, but he also sees adults, and he is trained in both. And then they also have some adult cardiologists who did special training in congenital heart disease, who staff that clinic as well. And when I go to national conferences, everyone looks at the Emory clinic actually as a model. Is how to run a successful adult congenital heart disease clinic. Other parts of the country, it is a mess, I'll tell you. They try to do the adults in the Children's Hospital. That gets complicated because the adults don't really get to be adults. They'll ship them off to another hospital that they're not affiliated with. There's lack of communication there. They don't know exactly what happened with the children. It's good that here we have that continuity, we have that set up in place. But we still have challenges here trying to transition our children to becoming adults responsible for their own care. Other recommendations, adolescents should be engaged in transitioning planning. We spent our whole time talking to the parents at the visits. As cardiologists, I think we need to do a better job of talking to the adolescents and getting them involved. Adolescents should be asked what they're understanding their disease. Adolescents should be encouraged to share concerns. We want to get them involved more. Adolescents' fears and concerns should be acknowledged. We should initiate and work together with the adolescent. And then 7's a big one. We should begin to direct health discussions more towards the adolescent than the parent. So when your child becomes 12 and older and you start seeing us talking more to them than you, don't be offended. It's a good thing. We want to work with you to have your child grow to be a responsible adult for their own care. You're not going to always be around to direct them. We want them to go off to college and be able to walk into the student health clinic and say, this is the surgery I had, this is what my concerns are, these are the medicines I'm on, this is what my cardiologist told me to worry about. We want that conversation to happen with the children to be able to do that. And then quality of life issues should be discussed privately with the adolescent. If we kick you out, it's not because we don't like you. It's because that helps the adolescent, almost forces the adolescent to start taking some control of their own care. As a group, we are still trying to come up with practices. Different cardiologists in our group do different things. But if you as a parent see that we're not doing that, step up, tell the cardiologist, I want you to talk, to John, sorry, adolescent. And get him involved. Or I'm going to step out. I know he has some concerns that he wants to share with you that he might not do with me here. I'm going to step out for a second. That's fine. And then last, adolescents be flexible, easier. What are we doing at Sibley? So if your child is 12 years or older and comes in, they should be having this form that the physician fills out. You may not see this form, but we should have this form that we're trying to fill out and go over with you. We're trying to address these things. A lot of adolescent concerns, and your adolescent will share a lot of the same concerns as other adolescents, but will also have their own set of issues. Education. Will they be able to get the education they need? What sort of things they need to know? And also education about their heart disease. We want them to know. I can't tell you how many times even at every, adults will come in the emergency room, scar in their chest, and like, I had heart surgery. Oh, what'd you have? I had congenital heart disease. Okay, that doesn't help. You know, it doesn't mean anything, you know, or they'll say, I have a pacemaker. Why? Your heart didn't beat right. Okay, what setting do you at? Where, I don't know, I just know it helps you beat. We want children to know what they have, especially as they get older. You know, if you're not around, you know, if they're on a sleepover, if they're on a camp trip, if they're, you know, off to college, we want them to know. Okay. Insurability, that becomes an issue, and I can't say a whole lot right now because things are changing, and that becomes political. Will they be insurable? You know, with the new plan, that becomes less of a complication, but a lot of the adults, it's harder for them to get insurable because all your kids have pre-existing conditions. Right? Next, babies. A lot of kids want to know, can I pass this on to my children? Diseases range from some, it's about 50% chance that they'll pass it on to their children, to very, very small chance that your children will have it. For females, pregnancy. This is a huge one. Right? This is very, very important. Pregnancy and, you know, contraception if needed. I won't get into a discussion, but what I'll say is that there are certain heart defects, especially with how children are doing, where pregnancy can be lethal to mom. Right? You need to have that discussion, and I think earlier the better, so that the girls, as they get older, are aware of what their concerns need to be. Is their heart in good shape? Are they someone who could go through a pregnancy? If not, is adoption or something else an option? You know, we an adult, you know, tell the kids, you know, tell women who come through, like, you know, yes, we can get you through pregnancy and you can be a mother, but you may not live to be a mom. And that's important for girls to understand. That you want to be a mom, we can talk about other ways that you can have a child without necessarily going through pregnancy. So it adds a huge hemodynamic load on the heart, as all of the mothers in here are aware. Healthy habits, we want to encourage healthy habits again. We want these hearts to do well. And then sports and exercise, as you asked about. You know, we'll talk, each condition's different, each child is different. It really becomes an individualized discussion to have with the family about what your sports and exercise can my child do, should my child do, and if needed, we can order other tests to evaluate the performance of the heart. I know you're getting a book today, but Hope for Heart in the Adult Congenital Clinic. We have a book here called Balancing Your Life with Congenital Heart Disease, and it's hard to read. And this is produced by one of our nurses in the Adult Congenital Heart Disease Clinic. I don't think it's too early to start looking at that book, and it's available online. You can read the full text of the book online. So the website is in your slides. I recommend you take a look at that and see if you would like. So you can start knowing what sort of issues do I need to be thinking about with my adolescent. So the big take-home point, the biggest challenges of children with congenital heart disease is appropriate transition to adulthood. Proper planning and counseling can help improve the lives of these children as they become responsible for their own care. And I know later today you're going to be talking about some of that with disability and other things. I'm very excited to see that that is something that you're all starting to think about now.
In October, we also have our Adolescent Transition Conference. For those of you who have kids 12 and up, that's an opportunity for your kids as well as you to attend to learn how to transition to adulthood.
So in conclusion, research has led to a greater understanding of development, diagnosis, management, and long-term outcomes. Further research is certainly needed. That's what we're trying to do more and more. We want to learn, we want to help these kids become, prospering adults in their lifetime. The future's unknown, but I think it's also very exciting, very promising. I want to leave on a high note and let you know that things are looking good. Things are heading in the right direction for children with heart disease right now, and I think things are only going to get better. Okay. Thank you very much.